Hello, everybody. My name is Jan De Waele. I'm an intensivist based in Ghent, Belgium, and it's a pleasure to be here with you at your meeting, although only virtually. I hope I can make a meaningful contribution. My topic today is optimizing antimicrobial therapy in sepsis and septic shock. And in the next 20 minutes, I will share with you some ideas, some new developments of how we can actually bring this to the bedside. These are my disclosures. As you can see, I'm involved in the ESICM. I'm the current president of the European Society of Intensive Care Medicine. And I am also involved in the Surviving Sepsis campaign guideline development. And this is where I would like to start off right away. This is a reference to the 2026 iteration of the guidelines, including the QR code that you can scan, and you can easily access the 2026 guidelines. I will be citing from them from time to time when they are relevant to this topic. Let us just briefly focus on the problem at hand. I think sepsis and antibiotic use are, of course, closely linked together, and we do still have a problem. As you know, survival rates of sepsis, septic shock, more particularly septic shock mortality rates up to 40-50% still. And at the same time, antibiotic use and overuse is a daily reality. A lot of our patients, 70% on average, and maybe higher in some parts of the world, are being administered. And much of this, or a lot of this, is inappropriate. It's being given too long. It's too broad spectrum. It's not the optimal treatment. So there's clearly a room for improvement. And this is the central theme of my presentation. So what defines antimicrobial success? And I think it's important to briefly reflect on that. Well, of course, intuitively, it's about giving the right antibiotic with the right spectrum at the right moment. Yes, and I will focus on that first. But after that, I'd like to briefly walk you through the latest evidence on dosing and administration of the drug. But first, let's look at the speed of antimicrobials, how fast we administer them, and how important this is. And as you can see, the literature is plenty when it comes to the reduced mortality, the improved outcomes when antibiotics are given early. The evidence base is quite strong, and this is, well, the first recommendation of the Surviving Sepsis guidelines I'd like you to point to is a strong recommendation. So that means that the majority of these patients should receive this treatment. In patients with possible, probable, or definite septic shock, it is recommended to administer antimicrobial therapy immediately and ideally within 1 hour of recognition. The rationale for that is pretty straightforward. We've seen in many studies and meta-analysis that indeed early administration reduces mortality, and it's the most consistent and the strongest in patients presenting with septic shock, and therefore delaying any therapy is something you don't want to do because the risk of mortality is just too high. This figure actually summarizes the current recommendations of surviving sepsis based on either the presence or absence of shock and the certainty of infection. But let it be clear, and this is what I just told you about, when septic shock is present, the administration of antimicrobial therapy within the hour immediately is what we recommend. In patients where shock is absent, so patients with sepsis, it's slightly different. There's two categories. If you're sure about the sepsis diagnosis, then again, the recommendation to administer antibiotics immediately and ideally within 1 hour of recognition. Whereas for other patients where sepsis could be the diagnosis, but a number of other diagnoses cannot be excluded right away, this is where, and shock is absent, of course, this is where there is time for this rapid assessment of infection versus potentially non-infectious causes of the acute disease. And if the uncertainty persists or you're still worried about the presence of infection, then after 3 hours, within 3 hours, antibiotics should still be administered. So you wait, you do your investigations, and if at 3 hours you're still unsure, go for antimicrobial therapy. So that was briefly on timing. I do want to mention also the importance of the appropriate empirical coverage. In this context, of course, it is important not only to give antibiotics that in time, but also antibiotics that actually work for the patient, and therefore a conditional recommendation when it comes to patients at risk for multi-drug resistant pathogens, that those patients are suggested to get empirical coverage that actually also includes this pathogen of concern. So that may be variable. In some parts of the world, it can be MRSA, in others it's Acinetobacter, in others it's Pseudomonas or APC, Enterobacterialis. If there is a concern, if there are risk factors also present, and they are listed here, they include prolonged antimicrobial use, prolonged hospitalization in the unit, and in the unit with a high prevalence of this MDR pathogen. Vice versa, new recommendation and the opposite, patients who are at low risk, the suggestion to cover these pathogens is to not do this. So the suggestion against using empirical antimicrobial therapy with coverage for this specific MDR pathogen, which I think is a logical conclusion of the previous recommendation. One other aspect that is new in the 2026 iteration of the guidelines is the importance of covering or not covering the anaerobes in the spectrum of the antibiotics. We've seen a lot of research into the microbiome, and we know that killing off the anaerobic flora does have consequences for the gut microbiome and critical illness. It is indeed a fact, and we do this in everyday clinical practice. We have a lot of our antibiotic combinations that are covering also anaerobic bacteria, whereas you may just not need them. So as an example, Pip/TAZ, clindamycin, meropenem, amoxiclav, broadly anti-anaerobic effect. And as you see at the lower part of this slide, in the EPIC-2 and 3 studies, the incidence of anaerobic infections is very low. It's like 1.2%, although half of the patients in the study actually received anti-anaerobic treatment. This led the, looking at the evidence, of course, supporting anaerobic coverage. The conditional recommendation is using an empiric antibiotic in patients without risk factors for anaerobic infection. So antibiotics that do not cover the anaerobes. There is one exception, of course, when you need a specific antibiotic to treat multi-drug resistant pathogens, and just by chance they also have an anti-anaerobe cover, it is still recommended to use that drug to treat the MDR pathogen. That's quite straightforward. And the rationale, again, low prevalence of anaerobe infections, observational data suggesting harm from anti-anaerobe treatment. So this is a clear recommendation. And of course, if risk factors are present for anaerobic infections, such as abdominal infection, head and neck necrotizing soft tissue, empyema, and brain abscesses, then still, of course, an anti-anaerobe spectrum of a drug is recommended. So that was some thoughts on timing and the empiric selection. Let's now focus more on the dosing and administration part, because a lot of new evidence has emerged that is impacting the way we treat these patients. The effects of critical illness have been well established. On the pharmacokinetics, we see that plasma concentrations go down because of the hyperdynamic circulation. Fluid balances also contribute, whereas organ dysfunction may lead to increased concentrations of a drug and organ support, and again, it could take it either way. End result of these pharmacokinetic changes in our patients are that the concentrations of a drug, including antimicrobials, are highly variable. This comes from a point prevalence study that was done some years ago that looked at mid-dose and end-of-dose concentrations of these beta-lactam drugs, and just look at the huge variation, the variability of the concentrations that are being encountered. It's really, I think it's really striking to see the wide range of concentrations that was found in these patients. Yet still, this is what we do, one-size-fits-all dosing for our antimicrobials and many drugs. The problem with antimicrobials is, of course, that you cannot measure the immediate effect of the drug compared to a vasopressor or a sedative. So how can we improve this? It's important to understand what the key principles are of optimized dosing. And I'd like to consider 3 elements. First of all, pharmacokinetics, pharmacodynamics driven therapy is important. You need to understand that what changes the PK and the PD is important. Now, the PK is essentially influenced by the volume of distribution, protein binding, and drug clearance. The clearance from the circulation, typically for beta-lactams and many other drugs, by the kidney. This results in a typical concentration time curve that you can see here. So a short infusion of the drug gets you a high peak, and then the concentration goes down. And depending on the drugs, there are different PK/PD targets. Time-dependent antibiotics, such as beta-lactam, it is important to keep the concentration above this minimum inhibitory concentration. Whereas in others, like aminoglycosides, it is important to have a high peak over MIC. And this means that every drug works in a different way to maximally kill off the pathogens. But it's not only the information about the drug and about the pharmacokinetics, it is also about looking at the patient and what changes these parameters. One key issue is kidney function. I already mentioned it before. And when we look at the range of clearances that we encounter in our patients, quite often when the drug clearance, the kidney clearance goes down, we are in the acute kidney injury setting where, of course, we are worried about potential overdosing. But it's important to understand that there's also something like augmented renal clearance that eliminates the antibiotics from the circulation more rapidly and more effectively. It's different phenomena leading to this, but essentially it's about the kidneys receiving an increased blood flow to the organ, but also changes in tubular function may play a role. So it is important to understand that this is happening, and you can only measure this when you are actually using measured creatinine clearances from your patients. So by looking at the formulas or by looking at creatinine concentration in a patient, you will not see or recognize augmented renal clearance. So the kidneys are important. And this concept of renal dosing is something we need to be very careful with. And this study looked at this. And the question here is, do we have to adapt the dose in the first 24 hours? What these investigators looked at is the trends in kidney function in patients who are admitted to the ICU. And as you can see, here's a number of things to see. This is the fractional change in serum creatinine that you can see from baseline over the 2 to 4 days after admission. And this is the average, all patients put together. In the panel B, these are the patients with acute kidney injury on admission, right? You see indeed that the creatinine level is high, but over the next few days, it goes down. You can even break that up in 2 different categories. These patients here in panel C, they have transient acute kidney injury, where those in D, acute kidney injury may persist. But especially those patients here, if you would dose them based on the first day creatinine levels, you may be risking to underdose the patients because they are actually, these kidneys are improving. And it's not a big surprise. It's because what we do, how we treat the patient, that makes our patients better. And a final element is the use of real-time drug monitoring. And I think we'll see much more of this in the future. So this is optimized dosing that is augmented through real-time monitoring. An important paradigm shift here is that we are no longer doing this for toxicity, but we are doing this for efficacy. This is a key issue. The data are quite supportive. This is a recent systematic review and meta-analysis, number of studies looking at overall mortality, as you can see here, trend in the right direction, favoring dose individualization, but target attainment, as you can see here, for the antibiotics, a clear advantage, better target attainment when you use TDM and you adapt the dose. Clinical cure, not statistically significant, but again, trends in the right direction. This led the Surviving Sepsis 2026 panel to conditionally recommend antimicrobial TDM, albeit on a case-by-case basis, looking at clinical features, patients at risk of under and overdosing, namely resistance patterns, local ecology, and of course, the availability of TDM. All of this is very important. So that was one aspect, the dosing aspect. I'd like to end with telling you a few things about how we administer the drug. And I already alluded to the pharmacokinetic changes and also the pharmacodynamics of the drug, how these drugs actually work. And for beta-lactams, we know that this concentration, keeping the concentration above a certain amount of the time, as long as possible, and preferably continuously above the MIC, that would be something to work for. So here on this panel on the left-hand side, you can see a concentration time curve after an intermittent bolus dosing. And here on the right, it's both extended infusion and continuous infusion that is depicted. So when you switch from intermittent to continuous infusion, you can see for different MICs, you get much more exposure, both at lower MICs, but also at higher MICs. So that's the theoretical background. The evidence is getting quite strong, and strongest contribution came from this study, the Blink-3 study, in which we here in Belgium also participated, mainly driven by our Australian and New Zealand colleagues. So in this study, more than 7,000 patients were randomized. It was a pragmatic study, randomized between continuous and intermittent infusion with all-cause mortality at day 90 as the primary endpoint. Baseline characteristics, quite sick patients, as you can see here, an Apache 2 score of almost 20, and the typical kind of patient that you see in your ICUs, pulmonary, intra-abdominal, and bloodstream infections being the most frequent. Let's now look at the outcomes. The primary outcome you can see here was in the adjusted analysis. This was a predefined adjusted analysis, a statistically significant difference with a lower mortality, 2.2 absolute reduction in mortality in patients receiving continuous infusion. There was also a higher clinical cure rate, as you can see here, which of course is also an important determinant. All the other outcomes were not statistically significant. Looking at different subgroups, and you can see it's all in the same direction, so that's quite solid, whether patients had pulmonary infections or something else, the type of antibiotics, age, sex, or Apache 2 score, basically the same effect across all patient categories. This was then fed into a systematic review and meta-analysis that was co-published with the Blink-3 results. 17 studies, more than 9,000 patients, supporting indeed the observations in the Blink study. Depending on whether you use Bayesian or frequentist approaches, there is a reduced mortality in patients receiving continuous prolonged infusion. Also, ICU mortality was lower, clinical cure was higher. So I think this intervention ticks all the boxes. Number needed to treat 26, according to the systematic review and meta-analysis. This led the Surviving Sepsis Campaign panel to upgrade the previous recommendation from conditional to a strong recommendation, recommending the use of prolonged infusion of beta-lactams for maintenance, always to be administered after a loading dose. Let that be clear. So these are two important aspects of optimizing the dosing. I just want to end with the duration of therapy. This is a schematic overview of the different things we do in antimicrobial stewardship programs, but also in optimizing therapy means not unnecessarily prolonging the antimicrobial. So two recommendations that I briefly want to highlight. One of them is a strong and upgraded recommendation to de-escalate patients in whom a confirmed microbiological diagnosis is there, and a conditional recommendation for using shorter over longer duration antimicrobial therapy. This was not revisited. The evidence base was already strong in the 2021 iteration of the guidelines, but as there was little to no new evidence available, this was carried over, just again confirming that recent trials demonstrate that shorter courses, typically 5 to 7 days, are non-inferior to longer courses, which typically would be 10 to 14 days. And it is important to understand that this is also an important aspect of stewardship. So what will the future bring us? I think we've already made a number of important steps. Still, we can continue to improve, of course, and I think in the future I see some opportunities to further refine empiric dosing regimens and optimizing the duration and the exposure of the drug. So more to follow and more to come in the next years for sure. So how do you approach it at the bedside? I think it's recommended to use the highest acceptable dose. For instance, for PIP-TAS, we use 16/2 grams per day and not the lower dose, so not Q6 and not Q8. And in other situations, you may use higher doses, such as for amikacin in critically ill patients. Package inserts sticks with 15 milligrams per kg, whereas studies have shown that higher, 20, 25, and even higher have been recommended. And the same goes true for vancomycin. Loading doses is to be considered, and this is always to be recommended, always to be used in patients receiving continuous infusion. I would recommend against reducing the dose during the first 24 hours, except maybe in patients who do not have any kidney function left, but always tailored to your patient characteristics. And this brings me to my conclusion. Just again emphasizing that antibiotic optimization not only is about the selection of the drug, but also the timing, when it is administered, how it's been dosed, and the strategy you are using. In shock patients, it is clear, and when infection is certain, it is also clear patients need to receive antibiotics early, immediately, and ideally within the hour. Empirical antibiotic therapy should always cover the range of pathogens you would expect, not only in terms of multi-drug resistant pathogens, but also the type of pathogen that causes the infection. Meningitis is different from urinary tract, is different from abdominal infections. When you do so, use PKPD to optimize the dose and the administration. That means prolonged infusion for beta-lactams. And TDM potentially will play a bigger role in the future. But always think short courses, de-escalate whenever possible, and do not forget that antimicrobial stewardship is a team sport, and it has to be multidisciplinary at every stage. And this is where I'd like to end, and I'll be happy to take any questions.